Hello, I'm Scoundrel from Shandong University Reproductive Medicine Research Center. My research direction is female reproductive metabolic disease. Today, let me take you to learn about PCOS, the most common reproductive endocrine metabolic disease. The title is PCOS, at the crossroad of metabolism and reproduction. I will introduce from the following four aspects: PCOS history, environmental factor, and PCOS. Review PCOS from a genetic evolutionary perspective, and a series of unresolved mystery about PCOS. First, let's sort out the history of PCOS. PCOS is an ancient disorder. PCOS-related records can date back to the BC era. Hippocrates, the father of Western medicine, in his diary, it is written that those women whose menstruation is less than 3 days or is merged are robust, with a healthy complexion and a masculine appearance. Yet, they are not concerned about bearing children, nor do they become pregnant. Ancient Roman obstetric and gynecologist Soranus. Sometimes it is also nature not to menstruate at all. It is nature in persons whose body are of a masculine type. We observed that the majority of those not menstruation are rather robust, like mannish and sterile women. The medieval doctor Moyes also mentioned that there are women whose skin is dry and hard, and whose nature resembles the nature of a man. However, if any woman's nature tends to be transformed to a nature of a man, this does not arise from medication, but is caused by heavy menstrual activity. One of the most famous surgeons in the Renaissance period, the father of modern surgery, Ambrose, found that many women, when their flowers or teams be stopped, degenerate after a manner into a certain male nature, whence they are called virgin. That is to say, stout or male women. Therefore, their voice is loud and big like unto a man, and they became bird. From this record, we can see that menstrual irregularity, masculine habitus, sub-infertility, and possible obesity are the signs of PCOS prototype. Until 1935, Stephen Lewis reported that 7 cases of women with bilateral polycystic enlargement of the ovary presenting with scattering menstruation or amenorrhea, infertility, and obesity, and named Stephen-Lewis syndrome. The term Stephen-Lewis syndrome began to be used commonly by the middle 1950s. Some investigators also began to use the term polycystic ovary disease (PCOD) and PCOS in the latter part of the 1950s. This is the letter Dr. Steen sent to bilateral ovarian welt patient Stephen-Lewis syndrome. By the early 1970s, we find that the 3 terms are being used in similar frequency. The use of the term Stephen-Lewis syndrome then began to decline gradually throughout the 1970s, becoming markedly less common after the middle 1980s. As the term PCOD and PCOS were used interchangeably, the term PCOS began to dominate by the early 1990s. In 1990, National Institute of Health proposed the first clinical diagnosis criteria for PCOS, including only one presence of clinical and or biochemical hyperandrogenism and oligo or amenorrhea anovulation. Later in 2003, the Rotterdam criteria used polycystic ovarian morphology on ultrasound as a new criteria to be added to the 2 previous criteria of NIH. The ASRM Society developed and enlarged the diagnosis of PCOS, requiring 2 of 3 features: anovulation or oligo-ovulation, clinical and or biochemical hyperandrogenism, and polycystic ovarian morphology seen on ultrasound. In 2006, the Androgen Excess Society considered that androgen excess is a central event in the development and pathogenesis of PCOS, and established that androgen excess should be present and accompanied by oligomenorrhea or PCOM or both of them. In 2011, Chinese PCOS diagnostic criteria born oligomenorrhea and irregular uterine bleeding are the prerequisite items. The Chinese standards focused more on menstrual abnormality. In 2013, Endocrine Society published the clinical practice guideline for PCOS diagnosis and treatment based on Rotterdam standards, and hyperandrogenism is central to the presentation in adolescents, whereas there is no consistent phenotype in postmenopausal women. In 2014, European Society of Endocrinology published a position statement and offered a critical endocrine and European perspective on the debate about the definition of PCOS. It is still based on Rotterdam standard, but with emphasis on the laboratory evaluation of androgen and other potential biomarkers of ovarian and metabolic dysfunction. GCMS or LCMS are recommended as a golden standard method for evaluating steroid hormone. In 2015, American Association of Clinical Endocrinologists and the Androgen Excess and PCOS Society posted their practice guideline, also based on Rotterdam standard. Free testosterone levels are more sensitive than the measurement of total testosterone for establishing the existence of androgen excess and should be ideally determined through equilibrium dialysis techniques. Next, new ultrasound machine allow diagnosis of PCOM in patients having at least 25 small follicles in the whole ovary. However, in 2018, recommendation from the International Evidence-Based Guideline for the Assessment and Management of PCOS was published. In this recommendation, based on the Rotterdam criteria, calculated free testosterone, free androgen index, or calculated bioavailable testosterone should be used to assess biochemical hyperandrogenism in the diagnosis of PCOS. High-quality assays such as LCMS should be used for the most accurate body assessment of total or free testosterone in PCOS. Use endovaginal ultrasound transducer with a frequency bandwidth more than 8. The threshold for PCOM on either ovary, follicle number per ovary more than 20, and an ovarian volume over 10 millimeters on either ovary, ensuring no corpus luteum, cyst, or dominant follicle are present. General agreement exists among special society guidelines about the diagnosis of PCOS. They are virtually the same with some disagreement. Let's discuss the disagreement with an example. For example, the antral follicle number. How should a true PCOM be defined? 25 follicle or 20 follicle? As we know, PCOM is not unique to patients with PCOS. PCOM can be found in 20 to 30% of normal women of childbearing age, and can also be seen after oral contraceptive amenorrhea. In 2014, Human Reproduction Update published a review paper to define the PCOM. This table shows the follicle number per ovary and ovarian volume in healthy women with a regular menstrual cycle and normal androgen. It was decided to use the 95% of such control population from the most complete recent studies, which induce a total of 1,127 women aged 18 to 40 years. The combined 95% of follicle number per ovary of all studies was 23 follicles. Recently, we also found some molecular biology supporting evidence. As we know, hyperandrogenism is the main reason for PCOS. Androgen acts mainly through its receptor, androgen receptor. AR is expressed in most tissues and organs and is a key molecular mediating the biological effects of androgen. Both the SNP and its N-terminal CEG repeat in the AR gene region were significantly associated with PCOS. AR knocked out mice, so hyperandrogenism, increased follicle atresia, and ovulation dysfunction. AR is regulated by FSH and involved in follicle development. AR also involved in both metabolic regulation, like adipose size, fatty liver, and so on. Our group found abnormal AR expression in granulosa cell of PCOS was significantly reduced, especially in the PCOM subtype. Correlation analysis of AR expression and clinical phenotypes revealed a different correlation pattern between AR and endocrine level in the PCOM and non-PCOM subgroups. AR was significantly positive correlated with FSH in the non-PCOM subtype, while AR was negatively correlated with LH level in the PCOM type. The pattern of correlation between these two groups changed as the mean follicle number defined for PCOM increased. At a mean follicle count more than 23, the previously correlation pattern disappeared, suggesting that there may be a disease transition point at this threshold. This study presents a correlation analysis at the molecular level with the clinical phenotype, suggesting that PCOM requires a more rigorous defined threshold. Maybe 23 is more reasonable, which you to find more evidence for more accurate diagnosis. PCOS is more than a reproductive disorder. It affects women's physical and mental health throughout their lives. Let's use data to talk. It has shown that PCOS patients account for 70 to 76% of the infertility population. The prevalence of obesity is 40 to 50%, and metabolic syndrome is 25% in patients with PCOS. PCOS patients also have significantly more complications during pregnancy than normal pregnant women, especially GDM. PCOM has a significantly higher risk of developing complications like type 2 diabetes, cardiovascular disease, and so on. In our country, the prevalence of PCOS among women of childbearing age was 5.61%, according to the data from 2012, more prevalent than diabetes. Some unpublished data show that PCOS has doubled in the last decade. PCOS is no longer just a reproductive system disease. It has gone beyond the field of obstetrics and gynecology to become a lifelong disease that affects the whole body and threatens women's physical and mental health. The name PCOS only represents the morphology characteristic of polycystic ovary, but does not really cover the essence of the disease, with its variable clinical manifestation and complex pathogenic mechanisms. One questionnaire survey showed that most primary care physicians agreed that the name PCOS is confusing and needs changing. This table shows the potential name. 87% primary care physicians suppose change the name as MRS. In the NIH evidence-based methodology workshop, a multidisciplinary steering committee believed the name PCOS is a distraction and an experiment to progress. It is time to expeditiously assign a name that reflects the complex metabolic hypothalamics, pituitary, ovarian, and adrenal interaction that characterize the syndrome, and their reproductive implication. The right name will enhance the recognition of this major public health issue for women, education outreach, branding, and public relations, and will assist expanding research support. Metabolic reproductive syndrome may be the right choice. Given the high heterogeneous nature of PCOS, its need for more accurate disease subtyping in the future, then each subtype is named separately. Welcome to join us to explore the puzzle of PCOS. Thank you for your listening.